Well, good afternoon, everybody, and thanks so much for joining us. Happy New Year. I hope you're all safe and staying warm this week during the cold weather. My name is Greg Olson. I'm the director of the New York State Office for Aging. Really excited to have this program today, and I'll formally introduce our four panelists that are with me, really to talk about hospice, understand a little bit more about palliative care, but more importantly, end-of-life choices that are available to you. End-of-life care and pain management are critically important parts of the continuum of healthcare. No more important than pediatrics and every other subspecialty from birth to death. Your wishes matter. That's something that's really important to our office and many other offices, and understanding what programs and services that will help you meet your wishes is critically important. We have all heard the word hospice. Many of you have probably heard the word palliative care, but do you really know the intricacies of it? What services are provided, how they're provided, where they're provided, who they're provided to, what the costs are. Hospice programs throughout the state are uniquely organized to assist people at the end of their lives, but we really do a subpar job in New York State in helping people understand what it is, and more importantly, how to access important end-of-life care. But we're really hoping to start to change that today, hence the guests that I have. So I'm really excited to introduce, and we'll start at the top from the state level. I'm really pleased to introduce Jean Chirico, who is the president and CEO of Hospice and Palliative Care Association of New York State. The mission of her organization is to promote the availability and accessibility of quality hospice and palliative care for persons in New York State confronting advanced, life-limiting illnesses or conditions, to associate with individuals and entities to promote such care, and to advise the public and others of the benefits and need for such care. So Jean, thanks for joining us. I'll next introduce Natalie Whitehurst, who's the Executive Director of Hospice of the North Country. She serves patients and families in Clinton and Franklin counties. Hospice of the North Country supports and encourages people and their families to determine their end-of-life care needs. Her leadership role includes the development and implementation of the organization's programs and services, and her passion for hospice care is rooted in her belief that everyone has a right to die with dignity and respect. Natalie, welcome. Next, I'd like to introduce Kathleen Lamity. She's the Director of Development and Communications at Hospice of the North Country. She graduated from SUNY New Paltz with a BA in Communication and uses her more than 20 years of healthcare communication and fundraising experience to shine a light on the importance of hospice care in the North Country. So welcome, Kathleen. And finally, Becky Prevey, who is the Executive Director of the Association on Aging in New York, which represents our 59 county offices for the aging. She's also the Vice President of Hospice of the North Country, immediate past president. She was also the Director of the Franklin County Office for the Aging, and prior to that, served 10 years as an acute care social worker. So Becky, welcome to you as well. So let's start at the top. Let's get the language out of the way. I will start with you, Jean, because you oversee a network very similar like Becky does. You oversee and work with the hospice programs throughout the state of New York. What is hospice?
Well, thank you all for having me today. Hospice is, it's a program that I think our country has embraced in terms of the right way. One of the few things our government did properly was to help adopt a hospice program, which is a benefit under Medicare and most other insurance companies, that cares for people near the end of their life. Hospice is an interdisciplinary approach, a holistic program providing support to not only the patient, but the entire family, caring for someone near the end of their life. The hospice program focuses on reducing suffering, alleviating pain, and that suffering and pain can come not just from physical ailments, but at the end of someone's life, we're dealing with spiritual, emotional, social issues as well. And the hospice team, which includes interdisciplinary approaches of social workers, nurses, doctors, they all work together with the family to identify, as you said, what are the wishes of the individual, what are their goals, how do they want to live until they die, and focus on the quality of their life until it ends. So hospice is a wraparound program that is offered through most insurance companies and helps alleviate suffering.
Yeah, thanks, Gene. And what I like about the approach is what matters to people should matter to all of us. You know, a provider's idea of what somebody may need versus what somebody and their family have talked about over the years, or where they are in that particular space, is so important. That's what I love about what you guys all do, is this is really person-centered and focused on the individual and their wishes at the end of their life. So Natalie, you are one of the member organizations. You represent Franklin and Clinton County, and there's a whole variety of folks like yourself around the state. I know in our chat box, we're going to put up the list of all the hospice programs in the state of New York. So if you're not from Franklin or Clinton, you know who to contact. But dive in a little bit more on that and tell us what services specifically hospice provides.
So as Jean mentioned, it's an interdisciplinary approach that we have to the care for not only the patient, but the family as well. So we have our nursing services, we have social work on staff, we have spiritual, and we also have bereavement. So those are services offered to the family to help them deal with the terminal diagnosis as the person comes on to services. So we have many other staff members as well that Jean mentioned, like our medical directors and such, that help to take care of both the patient and the family's needs.
And one of the things that people don't often realize in the services that we provide is that hospice is an all-inclusive capitated rate. So hospice is responsible for also providing all the medications that someone needs, all the hospital medical equipment that they might need, and any specialty services that they might need are the responsibility of the hospice. So it is truly a wraparound, all-inclusive program.
So let's dive into that a little bit more, Gene. Most people don't know what a capitated rate is, and they don't need to know. What does hospice cost? Let's just talk about that. So this is something that I may be eligible for, and I get a referral to you or to Natalie or Kathleen or one of the other programs. What's hospice going to cost me? How do I pay for that service?
So hospice is a benefit of Medicare. Most of hospice is paid for through the Medicare benefit, Medicaid, and then commercial insurers also contract with hospices to provide that service. So it actually is not an expensive service whatsoever to individuals. It is almost 100% covered by all these insurances.
Right, which I think is critically important. Why I wanted to ask you that question, because again, you know, people that don't know this because they're not dealing with these issues yet may be reluctant because there may be a cost to it. So, Gene, we talked a little bit about language in the beginning. You identified what hospice is. Again, there's terms, palliative care. The average person has no idea what that means. Tell me what palliative care means.
Sure. It can be a little confusing because palliative care is when you address the suffering and signs and symptoms of distress that someone might have to bring quality and relieve the suffering. So hospice is a type of palliative care, but not all palliative care is hospice. So some palliative care can be very specific to a particular symptom, where hospice provides complete, as I mentioned, wraparound service for the entire family unit. Palliative care, there are certain outpatient and inpatient palliative care programs. While somebody is seeking aggressive treatment or curative treatment, they might have some palliative care consultation to make sure that they're comfortable while they go after that treatment. Whereas on hospice, someone has elected to no longer seek that kind of treatment. And so the services that we provide are, while they no longer seek that type of treatment, they still want to be comfortable and have quality of life.
Okay. And the $1 million question, who is eligible to receive the service?
I feel like I keep talking here, but the people that are eligible would be someone who has reached that point where they no longer want to go to the hospital for treatment. They no longer want to seek that curative treatment. They're not looking to prolong their life beyond what is the natural end of their life. And that a physician has agreed that they have 6 months or less as a prognosis. And then they have the desire to remain comfortable, live out their days, and have some support wherever they are, whether they're in a home, a nursing home, an assisted living, etc.
Okay. Now, Kathleen, you are the development director, fundraiser, communications for Hospice of the North Country. Tell us a little bit about your role and how that benefits Hospice of the North Country.
Okay. Part of my role is organizing fundraising events and also helping other folks in the community hold fundraisers for us. And the other part of my job is communications, where basically I'm trying to get the word out and educate the community about what hospice is. And I'd like to talk a little bit about our organization, and I can start by saying our mission in honoring life is to help people of the North Country die in spiritual, mental, and physical comfort. We are a nonprofit organization, and we provide care in Clinton County and Northern Franklin County. And that area is about 130,000 people. When we started, there were two organizations. Both were in 1984 started as volunteer organizations. And then in 1992, we decided to merge and become Hospice of the North Country. I won't go into our medical care team because Natalie already covered that. I do want to point out that we have a wonderful group of volunteers in both counties. We rely on them to help us in the office and in the patient homes. We couldn't do it without them. So
as a matter of fact, the federal government made sure hospice wouldn't do without volunteers. And it's actually a mandate that all hospices use volunteers. Up to at least 5% of their total work needs to be done by volunteers, which is why the work that Kathleen does and her team is so important to also outreach to get volunteers to come to hospices. And the fundraising, although insurance may pay for the hospice services, most hospices like Natalie's and Kathleen's provide above and beyond what is required to assure someone's quality of life. And they might approve things that aren't normally covered.
Right, hence the reason for the fundraising, right? To either reduce the cost or eliminate it altogether. And I'm glad you talked about volunteers. You're talking our language. Whether it be hospice or the area agencies or hospitals or community-based organizations, we would not have nearly the infrastructure without the millions of people that give up their time every year. So Becky, in your current role, your past role, so you're part of the board, vice president, immediate past president, you are a caseworker in the community, you ran an office for the aging, you ran the New York Connects program in Franklin County, you were an acute care social worker. How would you recommend our network, 59 offices, 1,200 community-based organizations, both on the volunteer side, but also the identification and referral side, access this really important service?
Thanks, Greg, and thanks to the team on the call today. I think what you posed is a really great question, and it's hard to believe I'm in my 20th year in human services, and the change in the medical landscape in that tenure has been really amazing. So fast forward, rewind 10 plus years ago, people used to spend extensive amounts of time in acute care settings for chronic condition exacerbation. So you had an opportunity through the social work department and physicians to have a hospice conversation with repeated admissions. With the changes to Medicare observation status and now with the pandemic, you're seeing people with really significant chronic illnesses and terminal diagnoses that are now in their homes and communities, and they don't have the same touch with the physician, with the acute care facility as they did, 10 or 15 years ago. So what's really important from my lens in doing this in home visiting and now overseeing the association is that we know New York State is fourth in the nation as far as the older population is considered. We know that in the next 20 years, we're going to see the greatest population increase in those over the age of 85. And I know we're going to talk about this as far as the diagnosis to get hospice care, but a lot of the 1.5 million older New Yorkers and their families that we touch are eligible for hospice and palliative care services. And it's incumbent upon our service delivery system to be educated about hospice services and the fact that you don't need a physician's referral to have an informational session with your local hospice provider. And that's really what I want the takeaway for the Aging Services Network that's listening to this, as well as family members, is that you don't have to have a physician referral. You just have to know what resources are available in your community. And if you think someone is towards the end of their life and they no longer want to go to a nursing home or a skilled nursing facility, acute care facility, that you need to be comfortable having a hospice conversation. You don't need to be an expert. You just need to connect those dots.
Yeah, and I think we have a lot of work to do after this, which we'll do collectively with everybody here to continue to get that message out. So for Natalie and Kathleen, I'm going to give you two questions at once. Who should be making the decision about electing hospice, and how long does it take to actually start to receive the service, if obviously eligible?
So as far as who should be making that decision, so it should be something that you individually can start thinking about. You can have the conversation with your family. Your family and your loved ones can have that conversation with you if you are facing a terminal diagnosis and an illness, and like you said, you don't want to continue seeking any more life-saving treatment. So it's something that you as an individual can determine and have that conversation. You can have it with your family, you can have it with your physician, and you can reach out to hospice directly and ask us questions, and someone would be more than happy to have that conversation with you and let you know what is required and what the next steps would be.
And it is possible to start receiving hospice care after your first initial phone call that day. Our goal is to admit patients within a day or two.
Okay, and so again, back to points that all of you made on the who should make the decision. This is not driven by a physician or a clinical diagnosis. This is driven by the individual, which I think is really important. It goes right back to the mission that you talked about. Sorry, Jean?
Although the conversation can be driven by anybody, there is a requirement for a physician to agree that the person is nearing the end of their life. That's the only point I wanted to make.
Okay, no, that's great. So Kathleen, build upon that. Let's say make a call, you turn the service on. How often will a staff, a volunteer, some team member that you guys talked about, because it is multidisciplinary, visit the individual?
Well, it is dependent on the patient. Our admissions nurse will sit down with the patient, the caregivers, and they go over a care plan very specific to the needs of the patient. So I can't say every nurse goes once or twice a week. It's definitely personal to the patient.
So it changes. In hospice care, it's the team works with, as Kathleen said, the patient and the family to determine what their needs are. And as their needs increase, so do the visits. So as someone becomes perhaps more debilitated, you might see more visits coming into the home, versus some of our patients are up and around, making visits to other family members. Unlike traditional home care, where there has to be a homebound status, that's not a requirement for hospice. So again, quality of life is whatever each individual determines it to be.
Oh, and I'm glad you mentioned that, because that was one of my questions on the homebound status. So you answered that. And again, Becky, I'm going to come back to you, because I think one of the things we always try to do with all of these Facebook Lives is present information, make sure people are clear, but then have an action plan. So we've got the list of resources. Many of the folks that either are listening live or will listen are part of our network. Who are the real targets in our network that we want to be making sure have the information that's being provided today, so that those referrals and the comfort in making those referrals actually occurs?
So for us, it's the older adult themselves, it's their caregivers. And for our network, it is everyone that is engaged in providing services. So anyone from a home health aide to a case manager through Office for the Aging that is doing those home visits. My dream is for a hospice and palliative care assessment to happen in the same regard that we assess people for fall risks. So when we go in that home, we're looking at throw rugs, we're looking at any hazards that might be available. We also need to be looking through the same lens at, is this an individual who has a life-limiting disease or disease process? Does the family want to keep them in their home and community? And just as we assess for Medicare and Medicaid home care services, we need to be thinking not whether or not someone is eligible, because I think Jean raises a really good point. You do have to have a physician agree with you in order to enroll someone in hospice, but we need to be collectively thinking as a network when we're having those touch points that hospice is just as tangible for some of our clients as a home delivered meal is. And that's really what we want to do the educational piece about, because there are people and this is really unfortunate. There are people that hospice gets a referral on that either pass away in a facility before they get home. We've had people pass away in an ambulance in the driveway of a home when they had a hospice referral, or people that have lengths of stays that are less than 5 days in length, because then you don't get the benefit of social work. You don't get the benefit of, building the community around an individual and the holistic care that hospice provides. So that's really the intent of doing these for our network, is to make sure that we're educated and we're resourced to make sure that we're connecting those dots with community members and hospices across New York State.
Yeah, great. Thank
I love how you're presenting that, Becky, and I appreciate you connecting the dots between the fact that, not every individual has been fortunate enough to have an ongoing relationship with their physician. The physician bringing it up to the patients is not happening in the way that we would hope in our historical medical world. And so if individuals who are caring for someone in the community also resist talking about these things or even thinking through that lens, then the further isolates the individual who could really benefit from having a conversation even about hospice services. And we use the surprise question. So if you go into the home, if you think to yourself, would I be surprised if this person died within a year? That's usually a great indicator that we should start a conversation about this. If your answer is no, I wouldn't be surprised.
And Jean, just to follow up on that very briefly, I think especially for providers and family members, you can have an informational with your local hospice without a physician referral. So it can literally be a family member or a professional that calls the local hospice to say, Mrs. Smith would like an informational on your services. There's no commitment. You're not signing up for the service, but you have access to direct information from your hospice provider in real time to be able to make an educated decision.
Great. Now, Jean, in our world, caregivers are family, they're friends, they're neighbors, they're check and D, they're all the above. For hospice, does a caregiver have to be a family member?
No, it doesn't. It sounds like we would use the same definition. It can be your neighbor. It could be a group of friends. We've had people who agree to do it all together and take shifts. And it's not as if someone is saying that they're willing to be at the individual's bedside 24 hours a day. That's not the requirement. Hospice can't be there. The organization can't have people in the home 24 hours a day, but we do need an individual or a group of individuals willing to take responsibility should the patient need more additional supports or at least communication about changes and things like that. So it's not being there and holding the hand for 24 hours. It could be just being willing to be the coordination of the services.
So Kathleen, building upon that, does a caregiver, broadly defined as we did, always have to remain with the hospice patient?
The short answer is no. Each patient is different again, but early in the disease progression, there may be a lesser need for care, but as the disease progresses, people may have to spend more time with their loved one, monitoring pain levels, comfort level. But during that time, just to bring up volunteers again, we do have volunteers that can provide family respite. But certainly during the early stages of a disease, caregiving is not as intense as the disease progresses.
Okay, and let's talk.
Oh, I'm sorry.
No, go ahead, Nella.
I just think it's important to point out too that we don't ever turn someone away for services for not having a caregiver. So we've certainly had patients where there is no one And we work with them on that and we help them, but it's important to point out that if someone is alone and doesn't have that support, that they are not turned away from our services.
No, and I really appreciate you raising that. I mean, a lot of the folks that we have on our caseload don't have anybody, and it would be crazy not to be able to access the service because you don't have a
Right.
caregiver. So thank you for that clarification. Let's talk about the physical environment now. Are there any special equipment or changes to the home environment that need to occur in order to receive hospice?
Sometimes there may be a need for a person to have, like a hospital bed or other items such as that. And that's something that your case manager, once we're in the home and you're on our services, would assess, and hospice takes care of that. So any of your durable medical equipment, like we talked about, any of the medications that you'll need, hospice takes care of that. So we're responsible for getting that into the home and covering that and paying for that. It's not something that the patient or the family is responsible for paying for.
Okay, thank you. Now, Becky, again, given the variety of roles that you've played, what are some of the benefits that you have seen in those past roles to individuals and their families because they did receive this important end-of-life care?
So I think, end of life planning is a really personal decision that needs to be made in conjunction with the individual and their care team and their family. I can tell you I have attended end of life in a variety of different settings, including skilled nursing facilities, the hospital itself, and in homes and communities. And I think the value that hospice brings to the death and dying process is really that holistic care. It doesn't feel institutional. It feels very holistic. There's a lot of support. There's a lot of family dynamics at the end of life that hospice really helps facilitate conversations regarding. And quite frankly, they are the masters of pain and symptom management. And really that's the focus of what hospice does, is to support that individual and to make this journey the best that it can be. And I think, attending deaths of people that have died on hospice service it's a comforting time. They feel very, very supported. There's bereavement services that are ongoing once someone passes away. And, quite frankly, a lot of people choose to be in the environment they've lived their entire life in, whether that be their own home or possibly at a child's home. And really, they're the experts at this process that we're all going to go through at some point in our lives. And I just think, from our perspective, especially with what we do in home and community-based service planning, it's really the right option for a lot of people that we serve, and it's just not utilized to the level that it should be.
Thank you. And Kathleen, let me wrap this up before we get into the next segment with you. Does hospice include 24/7 care?
Hospice, we're not there 24/7, but we are definitely available 24/7. Our nurses are on call to field questions. They can make visits if it's deemed necessary. But that's why the family network is so important, because they are the true heroes of hospice care, I think, because they are the ones there caring for their loved one. But yes, we're absolutely available.
Outstanding.
I think it's important to know that should an individual's needs become so severe that the family doesn't feel that they can take care of the individual anymore, or the pain and symptom management can't be done in the home, every hospice either has their own inpatient unit available or they have a contract for inpatient services, so that there's never a we can't handle it. There's always a next step. And sometimes that is a 24/7 inpatient location.
Okay, thank you. Roger, if you would be so kind as to pull up the slides, we're going to mix it up a little bit. So what we've been talking about is a couple of the definitions. You know what hospice is, you know what palliative care is. We also talked a lot about, and there was a lot of info today about what hospice is. Now we're going to talk a little bit about what hospice isn't and address some of the common myths. If you can go back to slide 1, that would be great. And I'm going to turn it over to Kathleen to do a quick round robin on some of these myths and what the reality is.
Okay. A hospice house is where people go to die. That is not true. Although there are hospice houses, hospice takes place where the care needs, where the needs exist. And that's usually the patient's home. About 70% of hospice care takes place where the patient lives. Good care is very expensive. That's false. Medicare beneficiaries pay little or nothing for hospice, and most insurance plans, HMOs, and managed care plans include hospice coverage as related to the terminal diagnosis. And I do want to point out that we accept all patients regardless of their ability to pay. Hospice is only for people with cancer. Actually, more than half of hospice patients nationwide have a diagnosis other than cancer. They include end stages of chronic disease such as emphysema, cardiovascular disease, Alzheimer's. Hospice is only for old people. That is not true. Although the majority of hospice patients are older, hospice, we do serve people of all ages, including pediatric patients. And 16% of hospice patients are under the age of 65.
Next slide, please, Roger.
Disabled people cannot receive hospice care. That's a short answer. It's false. They absolutely can receive hospice care. People with disabilities are living longer, and they do generally die of the same diseases of the regular population. Hospice care ends with the passing of the patient. Absolutely not. We do offer bereavement services for 13 months and beyond the death of the loved one. And obviously, we don't stop at 13 months. If we need to talk to you or visit you 2 years after your loved one dies, we are certainly here. Hospice and palliative care are the same. Comfort care is the same as hospice care. We have covered this. These words, hospice care, palliative care, and comfort care, are used interchangeably, but they really shouldn't. As discussed earlier, hospice care, in order to receive it, you do need to give up curative treatments, whereas palliative care you can receive while you're receiving treatment. And that wraps up those myths.
All right, next slide, please. I believe Natalie.
So a physician referral is not a requirement. As Jean pointed out earlier, a physician review and confirmation of the diagnosis is needed, but anyone can make a referral to hospice. As far as hospice patients being drugged up and die on morphine, that is not correct. We review what the patient needs. Obviously, we want to keep patients comfortable and pain-free. That does not always involve the use of morphine, but when it is needed, they're not meant to be drugged up by any means. Hospice only focuses on the dying process. It's not true. Hospice really is about living. It's about making the best of the moments that you have left. We focus on living. We focus on happy moments, keeping people comfortable so that they can enjoy whatever time they have left. And we certainly do that with the help of all the team members. And hospice is there for when there is no hope. Hospice is about giving hope. Obviously, we all know at some point we're going to die. Unfortunately, some people do pass away much sooner than they would like to. So we are there to help to provide comfort and support and provide hope so that those living moments that you have left are more meaningful.
Okay, next slide, Jean.
Hospice is only for people who can accept death. Well, that is not true, because I think all of us would struggle if we were given a terminal diagnosis, and if we were asked, are we ready to accept death? The answer might be no, but hospice employees, workers, volunteers are all trained in how to help people move through their fears and move to a place where they can die peacefully and their family around them can be at a peaceful place as well. Once you choose hospice care, there is no turning back. Again, that's a false myth. There are built-in opportunities for the patient and or family caregiver to, it's called revoke hospice and take themselves off of hospice care. And there are also times where we call it hospice rehab, where patients actually perk up from the excellent care that they're receiving, the symptom control that they're receiving, and they may no longer qualify because their prognosis has improved. There actually is a study out there that supports the fact that the length of someone's life is extended when they come onto hospice care, not reduced, because, as I said, of the excellent symptom management that is provided. Hospice is only for the last few days of life. Well, if you look at New York State statistics, unfortunately, that feels like it's true, but that is a myth. Actually, the benefit from Medicare is written for people who've been given a 6-month prognosis, but that 6 month actually never runs out. Someone could be on hospice for over a year, although it's not often that that happens. There are built-in reviews every 60, 90 days by the physicians to say, do we still believe this person is at risk to die? And so obviously, we want people to have the benefits of the hospice services for as long as possible during their illness. 16, if you choose hospice care, you won't get other medical care. Again, that's a myth. If there were other medical needs that someone had, the hospice would determine if they were responsible to pay for it or if your other insurance would cover the medical care that you needed. So if there was a specialist for like a podiatrist, you were having some very serious toenail issues, the hospice would then look at that and say, okay, you need to go to the podiatrist, but we're going to help you figure out exactly where to put the billing. That's about the extent of it. It's not a refusal by any means of other medical care. But the hospice medical team would let you know if there were things that they felt may not be consistent with just living a quality of life.
Great, thank you. And while Roger's taking this down, and before we open it up for questions, I know a couple questions came in that you guys have covered twice, and repetition is always good. So let's do it a third time. What, Jean, go through again what the cost is for this service. You talked about Medicare, Medicaid, managed care, private insurance. Just if you could go through that one more time, that would be helpful.
Sure. So hospice is a covered service under almost every insurance provider. And the only expense to the patient is if there's a copay attached to or deductible attached to that benefit. But most insurance companies waive the deductible or significant copays because they know of the benefit of hospice services. So it's worth asking if you have a concern. Hospice covers more than your traditional insurance would cover.
And Kathleen, you had said, but for your program, because of the job that you have to do, there's no charge for anybody regardless. Is that what I heard you say?
Right.
Okay.
Yeah.
Great. So that those 16 myths, we have taken notes. We are going to fill the answers in and upload this so that people know what is not real and what is real. So Kelly, I'm going to open it up to you. Do we have any additional questions from folks who are listening today?
Yeah, great. Thank you, Greg. One of the questions that we received is that, we hear that physicians are at times the ones who are telling patients or families, it's not time for hospice yet. Could the panel maybe talk through how to navigate those conversations with a healthcare provider so that you could at least, get the physician on board for a hospice assessment?
I will. Go ahead.
I'll take a first stab at it. So this has happened obviously more than once, and hospices are very familiar with how to help with this. As we mentioned, anybody can contact the hospice, but then the hospice can reach out to the person's physician and have a conversation. So if the initial conversation with the hospice provider indicates that the hospice thinks someone might be eligible, they can help either have someone within the hospice team or their medical director do a doctor-to-doctor phone call to let the doctor know what's happening. Now, sometimes that can feel a little sticky, having a doctor-to-doctor conversation, but we can provide whatever supports to help these conversations to continue, education to the primary care physician, and also sometimes making the primary care physician aware that the family is ready to have a conversation can sometimes open the door, because many times it's the physician's fear that the family's not ready or the patient's not ready to hear that they may be appropriate. So we often encourage patients themselves to say, I think I want hospice, am I ready?
Yeah, that's helpful. And can I just answer it a little bit different based on what you have told me today? And you tell me if I'm on the money or not. So you don't need a physician referral, but you need a physician on board. The way to take an uncomfortable situation and relationship is that if I'm ready or I've had a conversation with my family, my physician doesn't think that I'm ready, I don't need to do anything more than contact you, get a free consult. And then because of your positions and your expertise, that conversation then you can have with the physician and take the individual right out of the mix.
I would say that yes, if the individual is comfortable with that. We do live in a society where many of our older adults are uncomfortable challenging physicians because they see it in a different position of power. So that's why sometimes we really encourage the individual themselves to let their doctor know, because they have this trust relationship that they're ready to have this conversation.
No, and I think you're right. And I'll bring it down. It's not just older people. So from a personal example, I had neck surgery. I had my first doctor said one thing. I got a second opinion, said something different. The second opinion wanted me to talk to the doctor. I'm like, I have no idea what to say. So the second opinion guy talked to the first and we developed a plan. So this is not an old age thing. This is a balance of power for all of us. And that's one strategy, a way to take away that uncomfortableness and have peers talking to peers.
Yes.
And Greg, just to tie into that from working in healthcare, it should be no surprise to anyone listening to this. End of life conversations are very difficult, even for professionals. So physicians are predicated really on fixing people, and end of life conversations are difficult. And when you talk about the power dynamic, it's not always easy to advocate with your own physician about what your wishes are. And it's not always easy for the physician to say, hey, you should think about hospice, if their thought process is you're trying to prolong things as long as you possibly can. So, I think that there's a responsibility both on the individual side and the physician side to be able to have those conversations. And the beautiful thing about being able to talk to your local hospice without a referral, you can have that conversation and do exactly what you said, Greg. You can say to hospice, this is really where I want to go. I don't know how to have this conversation, and hospice can do that on your behalf. So I think that's a great takeaway, but there needs to be understanding on both sides of that equation that it's not an easy conversation to have.
Kelly, do we have other questions?
We do, and I think this is a great follow-up question to our previous one, because it's about how to communicate with our family members. So oftentimes there will be several siblings that are helping in the care of an older parent, or and one of them may feel like, I think it might be time to talk to hospice, but the rest of the people on the team might feel that, oh, you're just trying to speed this up. How can people facilitate that conversation about explaining that no, hospice is not about speeding up the dying process, and help navigate those very difficult interfamily conversations?
Kelly, I'm going to take a stab at this as well. I think that's twofold. So I think if you're, what the Aging Network does and does very well, is exactly what you talked about. So we work with families with intensive dynamics on a daily basis. And so that could be the role of your local office for the aging if you're receiving support, but it could also be the role of having that hospice informational. So, say I did a referral here in Franklin and, Natalie's care manager came out, part of their job between case management and social work is to facilitate family conversations, which are very difficult. They're well-trained. It's a very person-centered approach. And that team that you get under the hospice service can facilitate those conversations among family members to come to a consensus. But at the end of the day, the focus is always going to be patient-centered, person-centered, how you can support that individual. And it's really important for families to know you don't need to navigate that on your own. There's a wealth of resources in New York State for you to be able to have a facilitated conversation that doesn't turn into, an unfortunate family dynamic where you don't make any progress.
Yeah, and I'd just like to add to that because you're talking about team members or family members that might want to go one route or another. They're not in charge. The person is. And so instead of, talk to the loved one, not talk at them. And it's really, again, their wishes and how they want to end their life, not how their kids or their grandkids think it should go, because that's not their decision to make. Kelly?
All right, and I want to share, we have a lot of really wonderful compliments to people who have been involved in hospice services, caring for loved ones, and just had such phenomenal experiences, and they just wanted to pass along their gratitude and their thankfulness.
So for all of you that are providing that incredible feedback by being touched by this program, reach out to yours and volunteer.
Oh, that's wonderful, Greg. Good point. The last question that we have, and I know it came up before, but one of our watchers was asking, does there need to be a disease? Like, what if you could just kind of summarize the criteria for participating in hospice?
So I didn't hear the first part. I'm sorry. So you just want the criteria to come on to hospice services?
Yes.
So again, it's that terminal diagnosis where the prognosis is 6 months or less. So that can mean a lot of different things. It's not always a straightforward answer that you're given from your doctor. So if you feel that you or your loved one could be on that trajectory, it would certainly be worth a call, pick up the phone, call your local hospice for an informational. We can help and reach out to your physician as well and kind of, do some medical digging, so to speak, to help you with that, to determine that.
And I think that if I understood, part of the question was, does there have to be a particular diagnosis?
Mm-hmm.
And I just want to clarify that there's not one diagnosis that qualifies somebody, and somebody could have like a multitude of what we might call small diagnoses, not one large one that is going to end their life, but it's the hospice medical director's job to figure out how all these issues that someone is having play together to put their life at risk. So the main thing is this person's life at risk to end within the next 6 months?
Great. Well, I got to be honest, I can't thank you guys enough for joining me today. This is something we're very committed to. We look forward to future collaborations. I think there's a lot of really important info that you were able to share. Your passion and commitment is abundantly clear. So I thank you for that. We also have information about what hospice isn't. We've posted the resources of all the hospice programs in the state of New York. We will upload the myth chart with the answers associated to that. But Becky, Natalie, Jean, Kathleen, thank you so much for being here today and for the work that you do. That's really important. And as I said, I think there's a lot more we can do to educate and try to make better connections. I want to thank Roger and Kelly for my communications team, who somehow flawlessly always are able to pull this off and do it with just incredible competence. So thank you. We'll be back next week with our friends and colleagues from the Office of Alcohol and Substance Abuse Services to talk about prevention and helping individuals that might have alcohol, substance abuse problem gambling, particularly targeted to older adults, but it's relevant to anybody. And for all of you, again, please stay safe. If you're not vaccinated, get vaccinated. If you're not boosted, get boosted. Wear a mask, good personal hygiene, hand hygiene, and social distance. We're not out of the woods yet. And for those of you who are listening, the best ways to get information out is through you. You have email, you have social media, you have friends, you have networks. Share this information, help us help others, help us help you. We'll see you in about a week. Thank you so much.
Thank you.